You feel awful about this.
Me teaching, so I won't be here till Friday.
Oh, okay.
Emily. Oh.
Hi there.
Afternoon. Nikki, you're in your cabin.
It's where I live. Out in the woods.
Just had 2 weeks in the Catskills.
Nice. Very nice.
It's great.
Yeah. I'm going to Alaska next week.
Fun.
Nice.
Yes. Yeah.
It's my dream trip.
It is ours as well. So
Are you going by cruise or
we are
land?
we're doing a cruise, but we have 4 days on land. So
Oh, nice. That's a good combo.
Yes.
So you can.
Yes. I've never been on a cruise.
I made the mistake. It was always a trip that I wanted to take too, and I made the mistake. I was so eager to go, and so I booked the first week after a short legislative session ended in May, and it was quite cold. I don't think I left like 3-4 layers of sweatshirts and jogging pants, but it was amazing. So I wish you an enjoyable trip, Nikki.
Thank you. Thank you.
Picked a better time than I.
Yeah. Well, we are expecting like 55 and pretty much rain every day, but I'll take it. I do not like the humidity that we've had.
The Kaladi Brothers coffee is really good up there. It's like their local version of like a specialty coffee shop. So if you're in Anchorage or something, try it out.
Oh, you better bring it back for all of us, and we'll have to make a pot when we have our in-person meeting.
There you go. I will look for that. Thank you.
And Mickey, I don't know, depending on your cruise line, but sometimes they curate these fishing expeditions, and you can catch amazing fish, and they will cook it for you for dinner on the cruise. So you can catch and eat your own whatever you fish.
Yeah, my husband is a huge fisherman, so. I'm hoping to see a grizzly bear.
From far away.
Come to West Hartford. We have a couple too.
Yeah, not in West. Well, I think you have black bears in West Hartford. If you see a grizzly in West Hartford, I think we ought to be alarmed.
That's one of those cultural things out there. Like in one of the hotels in downtown Anchorage, there's a stuffed bear, and it has like a plaque that this bear was shot by Senator so-and-so using this type of pistol on this date. And it's like highly prized to show that off out there. Very different culture.
I think for the grizzlies, you lie down. So if you do see a grizzly in West Hartford, you play dead. I'm pretty sure grizzlies is play dead, and black bears, you make noise and make yourself big. Andy Tiffin when you're walking around the Capitol.
I live deep in the woods in Stafford, and we have black bears on our property all the time. In fact, one just ate one of my goats.
Oh my gosh, no,
Yeah,
it's
yeah.
terrible.
There's a lot. That's nature, right? So yeah, it's pretty awful, but they're here, and there's lots of them.
How do we look, Emily? Are we good to get going? What do you think?
Yes, I believe so.
Okay.
Yes.
Looks good.
So if you are an appointed member of the TCB or designee, if you could please put your name in the chat for attendance purposes, and I will share the agenda for the day. So the first item is the acceptance of the June meeting minutes, and then we will have some administrative updates, a discussion around current challenges, a UCC technical assistance update, and lastly, a presentation from Caroline on child and adolescent integrated behavioral health, fiscal map, and analysis. So to begin us off, I will put a motion forward to approve the June minutes.
Second.
There a second? Is there any revisions or changes? Sorry.
Second.
Okay.
Thank you. So I will then begin us off with some administrative updates. So I wanted to put this slide on here because there will be no TCB meetings in August, a monthly committee meeting or a work group meeting. So the next work group meetings will be in September. So system infrastructure will meet September 16th, services will meet September 10th, prevention will meet September 18th, and school-based work group will meet September 8th. So within the next few weeks, we will be connecting with work group co-chairs to discuss and walk through current work plans and identify any looming questions either the chairs or work group members may need clarity on. And then in August, we are planning to have an in-person meeting with the TCB leadership. So this includes the tri-chairs, work group co-chairs, and then us at TYJI to discuss current and upcoming TCB work and work group focus areas. So in April and May, we had Health Equity Solutions come to these TCB monthly meetings, and we have been working with them along with the Community Voices work group to plan out a summit for the fall. The tentative date for this is October 10th during business hours. More information will come, and next week sometime, appointed members, designees, and work group co-chairs will receive a survey to inquire if you are able to come and participate. The survey will then be open to work group members and others on the call if we do not meet max capacity of the summit venue. If you have any further questions regarding the summit, please feel free to contact me. And then last month, Jill Farrell from Yukon Innovations Institute came to our monthly meeting to provide an overview of the Children's Behavioral Health Provider Survey that we've been working on in the Services Work Group and Services Array subgroup. The survey is now live, and we did make a OneDrive with resources, which is linked on the TCB Connecticut General Assembly page, as well as within the email Jill and Kristen sent out to the TCB yesterday. For any questions regarding the survey or those informational resources, please contact Jill and Kristen. And that is all, I believe. Erica, I'm not sure if you have anything to add for administrative updates.
No, great job. Thank you.
Excuse me, Emily,
Yes.
although I know we haven't settled on a date yet, should we let people know that both September and October may be shifting with apologies, but it happens because of holidays and proximity to those holidays and also Jewish holidays. So we'll be back in touch with everyone as we figure out the dates. So I just wanted to give you a heads up on that.
Yes, thank you for that. I will be updating the September and October meeting times, hopefully within the next week or so. If there are any questions, please feel free to reach out. So I will now pass it to the tri-chairs for a discussion around current challenges and potential solutions.
I'm sorry, I missed then because we don't have the thing up. We're doing which piece of it right now? Duh.
Oh, the discussion around current challenges.
Okay. Oh, the current challenges one. Got it. Okay. I thought we were going to do a financial update first for where we are in terms of funding programs. Claudio?
Sure. So just a couple things. One, we now have the OFA draft write-up for the budget, which provides a little bit more guidance and legislative intent for some of the items that were funded in the budget related to our recommendations at TCB, which is very helpful. I would consider that, potential strategies around implementing that. So just to call out a few, one, we now have much more clarity around funding that was put in DSS's budget to institute the ICAP study that was part of the recommendation that TCB had put forward. Funding was in the budget while the bill didn't pass. The legislative intent was written into the OFA budget book, and that, in close coordination with working with DSS, is going to be allowing us to operationalize and move forward with that important initiative. Couple other things that we have discussed as issues that we need to work through. One is something that I know Alice had flagged earlier about how do we make sure that there's some bridge funding, patching together some remaining ARPA dollars, some potential retention dollars at DCF, and as may be needed through other braided resources to get through FY26 and maintain the 24/7 mobile crisis expansion. We know we are good after that. There's a very clear legislative addition in the budget to cover the 24/7 expansion that first initiated under ARPA. So I'm feeling very good that 27 and beyond, built into our current services, we will have that 24/7 mobile crisis for children. It's just patching together and figuring out how we make it through 26. But we're committed to working with DCF and the provider network to continue to identify the resources needed to get to 27. In terms of other strategies, I would say the number one recommendation of TCB obviously was around funding and rate increases that may be needed to support access needs across mental and behavioral health, and proud that the budget did put in really significant down payment on those Medicaid rate study identified areas that we wanted to plus up. So there's 15.4 million state share in 26. That's important because you would at least double that for the total impact on the provider network. So you're looking at 30 plus million of investment in 26, and then 45 million, roughly 90 million when you add in the federal share for 27. The budget did call out some areas of prioritization, and OPM is working very closely with DSS and our sister agencies to identify access needs based on the rate study of how we would deploy some of those resources. But what we do know is the budget did call out specifically an investment, a 3-year investment in the FQHCs that ultimately will annualize at about $80 million in the third year. So significant investment for FQHCs. That is important because it's an area where individuals, regardless of ability to pay, can go to access services. So underinsured, uninsured, Medicaid clients and commercially insured can go, and they would pay on a sliding fee scale. And the funding that we put in place also supports the fact that many of these FQHCs do holistic care, both mental health support and primary care. Many also have dental, and many are affiliated and included in school-based health centers and work in schools. So really important investment that was called out within the Medicaid rate increases. I suspect in the near future, we're going to have a more granular proposal for how all of the pieces of the Medicaid rate increase will roll out by code and by provider type. So more to come as we work through that. But I know behavioral health both adult and children was one of the areas that is a high priority that DSS is looking at. The last thing I'll just tee up, because I know Fatmata, Deputy Medicaid Director from DSS, is here to give us more detail, but in terms of the urgent crisis centers, a lot of work has been done and a lot of conversations about how we support a three-prong attack. Certainly making sure that commercial insurers are able to recognize, include them in network, and establish a rate that's commensurate with the valuable services they provide, especially in delaying or diverting costly emergency department placements. The second piece, obviously, and DSS deserves a lot of credit for the technical assistance and all of the work and feedback they've heard from the UCCs and how they're calibrating to make sure that we're streamlining our billing and hitting those targets that have been assumed in the budget. And we want to make sure get out to support the Medicaid patients that are seeing UCCs. And then expediting and trying to get some resources with bridge funding, knowing that there's going to be a path where as you increase your volumes and as you get to commercial billing and Medicaid billing, there's going to be a need for some wraparound bridge funding that was added in the budget that's going to be operationalized to help provide some of that transition. I think I'll pause there and see if there's any questions. I don't want to go too much in UCCs and take away Fatmata's thunder. So I'll pause for any other questions.
Alice?
Thank you. Thanks so much, Claudio, for the update. Just for clarification, the MCIS 24/7, for someone like Clifford Beers is about $1.2 million, was removed from our payment. And there is a meeting we've requested with the CFO from DCF. But frankly, they're just looking for any unspent COVID dollars that we have. It's the way that we were talking about, and maybe I, was confused when we met last time, but right now, because we were required to spend it, we have spent all of our dollars. So we will not have those dollars to be able to continue 24/7, even though it's July 23rd and we're still doing 24/7, because it's the right thing to do. But we're not going to be able to continue that, and there is no extra dollars that could be carried over. So I just want to make sure that that's clear to you, that they're asking for our unspent dollars as opposed to what I was thinking is DCF had unspent COVID dollars. So unless someone from DCF is on this call, I just want to make sure that that's clear.
Yeah, there may be, I think there's a designee from DCF that may be able to provide a little more information. My understanding, Alice, is that not every mobile crisis provider is exactly situated the same way. So whereas your position, I do believe that to be the case for you, I think there are other 24/7 providers that have sort of stretched out the resources. And so DCF, last time we were able to connect, is taking a full inventory across all those providers that expanded to 24/7 and seeing where their spend is with respect to ARPA remaining balance that had been provided that is expendable through the end of 26 and any retention dollars. So yes, you may have that position that we need to sort of figure out and maybe differently situated than some of the other peer providers, but we are also looking at how some of the 24/7 expansions are in a little bit better footing and maybe not need as much braided funding from other resources. But if DCF folks are on and wish to provide, I see Finn. I don't know if you or if Dr. Taylor or Frank Gregory may want to opine.
Yeah, hi, Claudio, and I think the commissioner might be on as well, but you're right. We are looking at all available options, and starting with any ARPA dollars that are currently unspent, particularly those dollars that are committed to that program. I think we have a little bit of a runway here, as we discussed, to sort all that out. Our CFO is working diligently with our providers to get that total number of dollars available. It's an unfortunate gap that exists in the budget, and the good news is it really focuses on the 24/7 aspect of the program. Obviously, the regular funding for mobile crisis continues on in the budget as it always has. So it's really about trying to find a way to knit together dollars to get us to July 1st of next year when the state budget does pick up that additional cost. So again, still working it out, sorting all things out, but we are committed to making sure that the 24/7 operations remain in operation and just get us through this fiscal year.
Thank you. Oh, if someone else, I'm sorry. I was just going to say, Vin, thank you for that, and we appreciate it. I just need, because we're a transforming committee, and I want to put my stake in the ground as a private provider in the community in New Haven that is very committed to the work in our region for crisis. We are continuing to run this program not funded, right? For as long as we possibly can, but we don't have that kind of dollars to be able to do it on an extensive period. So the runway is getting shorter and shorter as these dollars go away and programs get changed. So I just want us to really understand from a provider's point of view, we're trying to do the best we can, but it's very impossible to do it without the funding. And our runway is short. Our meeting was just changed to August 12th, so I'll predict we'll probably be running this program be asked to be running this program for 3 months with no funding. Thank you.
Alice, thank you for that. I think that what you are really leading us into, and Javid, I'll get to you in just one sec. What you're really leading us into is the next phase of what we're going to talk about, which is the cuts across the state, the cuts across programming. And we really do want to hear from you all. And we know it's a really difficult conversation. So we want to put a time limitation on it, because otherwise we could go down a very dark hole. So thank you for that, Alice. And Javid, would you like to add on?
Yeah, so we're not a home to one of these centers, but I just wanted to say, in empathy for Alice, her agency, and my other colleagues who have these centers, it really is a bit of a potential failure of us as a group if we're putting providers in the same position that providers have been, which is where we're caring for the most vulnerable young people in this state at a cost to us. So I just have to voice that to me is something that requires us to hold up the mirror as a state, as a committee. We have aspirations, we have celebrations, we're self-congratulatory at times, but I think that there's a tension here that we should be leaning into and asking ourselves what more we can do, because this is not fulfilling the promise of the legislation to put providers like Alice and her agency in this position. Thanks.
Thank you. Thank you for your comment. So this is not going to be new information to anyone, but just
sorry, Senator Moore, there's one more hand raised. I'm sorry, didn't want to interrupt. One more hand raised.
Well, actually, if I could ask Nuccio to hang on just
okay.
one second, so that I can frame the conversation going forward, and I'll get to you in a sec, Rep. Nuccio. This is not new information to anyone, but we're just going to frame where we are from a funding standpoint across the state. I'm not going to address the funding to schools, but you all know that schools have been cut in terms of their funding, and certainly for the most vulnerable. Within Medicaid, we're looking at 138,000 to 156,000 residents, including children, seniors, and people with disabilities, who will lose Medicaid due to the new work requirements and stricter eligibility. Medicaid funding to Planned Parenthood, which does more, obviously, than abortions. It provides health care, has been frozen for a year, threatening over $12 million in clinic resources. SNAP benefits is a potential $200 million cost to the state. And there's one other piece that nobody's really talking about, which is the fact that this bill also included a sequestration trigger, which will cut 4% across the board to all federal funding, including Medicare. So the state has put aside $700 million to help mitigate the effects of these reduction in state grants. However, Medicaid alone is $1.3 billion a year. So 700 million is not going to go very far. And I'm only framing it this way because it's not good news. We all know it's not good news, but now I need to hear from you. So Rep. Nuccio, do you want to take it away?
Sure. I'd before I get into any of that, I'd like to talk about the Alice. Are you guys private billing? And I would like to understand the difference between, you know, all the organizations that got ARPA funding for the 24/7, you know, that goes back to 5001 that myself and Tammy Exum, Rep Exum worked on, got that passed. So I'm wondering what's different in your organization than everybody else who still has the ARPA money, but more importantly, and secondly, are you guys accessing the private billing option from, because in the beginning, I know nobody wanted to bill insurance companies for some reason. So trying to figure out what's going on in your area that's different than everybody else.
We absolutely bill second party and all insurances, those that have contract with us, and Medicaid. And you know, we're about the Clifford Beers Community Care Center, which is the group, about a $20 million organization. Some of the organizations are bigger than ours, maybe 4 or 5 times bigger, that do NCIS. So they have a little bit more of a depth in terms of cash resources and being able to do that. But we worked really hard during COVID, Representative Nuccio, to fully staff our mobile crisis because of COVID and the crisis that was happening in our community. So a lot of funding that might have been unspent would be related to the unfilled positions, but we were full, and we had filled all of our positions. So there's a you know, 3 or 4 different dynamics around size, depth of runway in terms of dollars spent, as well as you know, empty positions. But I'm only speaking for our organization. Happy to go over the numbers with you and show.
That'd be great. And I just want to make sure we're optimizing and definitely private billing for regular commercial insurance when we have the opportunity to. So that way it's not just reliant on the state dollars, and that we definitely have to be sure that we are private billing.
Yeah.
Whether it's the UCCs or the 24, like all of it. So
Right.
I know there's a meeting coming up with Claudio, when me and a couple other people to look at making sure we have the availability to do that in the insurance world. So
Unfortunately, with insurance, and you and I have had this conversation, they pay maybe somewhere for us. And again, because we negotiate our contracts and, you know, it's all individuals, somewhere between $20 and $30 less than Medicaid right now. So, you know, if Medicaid, let's say hypothetically pays $100, they'll pay 70. So
okay. That might be part of what the meeting is about. I know Claudio is
so,
on,
yeah.
if he wants to, but I know we're talking, we are sitting down to talk about how we can kind of bridge that. So thank you. If you want to send me that data, you know, if there's anything I can look at to kind of try to help you guys analyze, I'd appreciate it.
Sure, thank you so much.
And then I just want to, you know, I understand like a lot of the consternation about what's going to happen in Medicaid in the next after 2027 and that. I just want to make sure we're keeping this all fact-based and all of that, because I don't think, you know, Senator Mar, as far as I've been able to tell with OPM and that, any of the changes to Medicaid are not going to impact children. They are 19 to 64-year-old able-bodied, and I've been assured by DSS that about 80% of our recipients of Medicaid are already working, so it wouldn't impact them. I'm trying to sit down with them to get a look at the breakdown in actual numbers, so we're not theoretically putting information out that may or may not be, you know, unintentionally or inflammatory. So I just I don't think any of the changes are supposed to impact anybody on Medicaid A or B, with a dependent under the age of 14. So just kind of trying to keep it in perspective.
Is there anyone else that would like to say anything? If not, we can move on to the next part of our agenda. Emily?
Thank you. And I will give the floor to Fatmata Williams.
Thank you, Emily. Senator Mayor and everyone on this call, good afternoon.
Good afternoon.
Yes, for those who don't know me, I'm Fatmata Williams, the Deputy Medicaid Director, and I'm here to give an update on some of the work that we have been doing with the UCCs to help them specifically around Medicaid billing, understanding that there are other parts to this, and Claudio just highlighted that. And Claudio, you can steal my thunder any day. I'm fine with that. All right, so just to provide a quick background, effective April 1st of 2024, we created a fee schedule to allow the UCCs to begin to bill for the services under Medicaid because the APA funds were winding down. We worked very quickly and created all of these codes that they could use, and they were part of that process. But quickly, we started realizing that, they kept reaching out to us that they're having problems billing some of the codes that we jointly put together on the fee schedule. So we decided to do a quick data run, and we found out. Can you hear me?
I was like, let me submit this
Can somebody
before
mute
people
themselves,
go away.
please? Hello, mute yourself,
So
please.
I've been sitting here, I'm trying to submit the framework, and it's saying that it exceeds the maximum
Emily,
size
can you?
allowed.
Yep. Thank you.
Thank you. So before we met, we did a quick data run, and we realized that from April 1st of 2024 to May 20th of 2025, together, the three UCCs had seen distinct patient counts of 4,286 members. They had 3 billing providers, obviously the three UCCs, and they had 125 performing providers. The largest biller was the Village for Families, where they billed 2,574 members. Wellmore billed for 783, and the Child and Family Agency billed for 933. And as we continued doing our assessment, we realized that they were billing just one or two codes, and those codes were the evaluation codes 97091 and 97092. So they came together with they had consultants buried on. We had DSS, DCF, and we had our auditing folks all on the call, and we identified exactly what was going on, that we had all of these codes on the fee schedule, and they were not billing those codes. They were only focusing on the evaluation codes. Then they highlighted that they had issues with billing two codes at the same time, because in essence, when a kid has a crisis, they have to provide overlapping services. So the nurse could be doing the assessment, the psychologist could come at the same time to talk to the kid and family. So they felt that that was going to create an issue with auditing. So we had our auditing director, meet with them and provide specific details around how they could document, and we let them, we've had like 4 meetings so far, but they came back to meet us and said that that is still not working, and that they're worried because there is a CMS guideline that has to do with correct coding initiatives that states that you cannot build two codes together. And so they're really worried about this, even with all of the technical assistance that we have given to them. So they came to us requesting case rates and Medicaid supplemental payments. They mentioned that they are working with some insurance companies. I believe they have signed contracts with about 4 insurance companies: Aetna, United, Cigna, and I believe Anthem, which is Carolyn for them. So that's good news because at least there's some commercial business coming in. But they're insisting that we still need to do something about the fee for service payments, that's not working for them. So we decided to take a look again at the fee schedule and ask them to look at the codes that are on our fee schedule and those that do not intersect, meaning those that are not going to bump against each other. Can we look at collapsing some of those codes and increasing the rates so that way they're able to bill? Because for the range we looked at, they only billed maybe 1.2 million, really low in terms of what's really available to them. So they're willing to go back and look at those codes. And DSS is also going to have an internal meeting to look at the codes, make our own proposal, and see what they're going to come with. So in essence, we have a follow-up meeting with them on, I believe, August 11th for follow-up. And we also talked about ways that they could do a lot more advertising about their services to ensure that they're getting referrals, because based on the data from CHDI, 40% of the referrals come from schools to the UCC. So we wanted to know what they were doing in terms of boosting the advertisement, even within the schools. And they identified challenges such as, they said, based on this federal regulations, school social workers may be laid off, and that could impact the level of referrals they may get from schools. They're doing collaborations, they said, with hospitals in terms of having patients being redirected to the urgent care centers. But again, they cited that the Emergency Medical Treatment and Labor Act, the EMTALA law, which requires that when someone goes to the ED, you have to treat them, is a barrier again to having that connection with the hospitals. But they did say that CCMC, now when a child shows up for crisis that they felt could have been treated at a UCC, they would treat them but give them a brochure to say, okay, the next time you feel this way, please go over to, and they will send them to, I believe it is maybe the village, anyway, one of the UCC, the UCC in Hartford. So there is all of that going on, and they're doing a lot of work with the ambulance companies as well to redirect for them to be able to make decisions to get members to the UCC. So there's a lot of other work going on in addition to us working with them, and they have a goal to increase the patients that they see per day to between 6 and 7 is what they're saying, up to 4,200 a year. And I believe that is per UCC. So that is what I have in a nutshell. The follow-up is there will be another meeting on August 11th, and we can always come back and provide an update if necessary to you guys. And I'm open to questions you may have.
Yeah, I see Howard up, but before you do, Fatmata, just a couple intersection points. Yeah, I know you're aware, but I'm going to bring it together for the group here. Is we're completely aligned with you on the rates plus volumes equals sustainability. I heard that from Caroline, and I keep channeling that wherever we can. And I think you're smart to pick up on where the utilization is, where there's an opportunity to build it up. I know my tri-chairs and I have worked really hard to change the culture, because some of this it's a brand new service type, and it's getting trusted validators to say, yeah, this is the right intervention. This is the thing you should do. And that's going to take a little bit of time. But I'm appreciative and want to connect that TCB is also going to be looking at the crisis continuum with an eye towards this. What can we do as better points of referral, maybe at broader points of the day? I know Representative Nuccio has thought about creative options to braiding in law enforcement, police as a way to avoid more escalated police intervention, if that's an opportunity to get more referrals. So very much like that you included in there the conversation about increasing volumes and utilization. That's going to be key, and it'll dovetail nicely with the work that TCB is going to embark on and that we have funding to do in this upcoming year.
Great. Thanks,
Howard?
Claudia.
Yeah, hi Fatmata.
Hi, Howard.
And thank you for the work you're doing and the collaboration with our providers. Just to continue the conversation around sustainability that Claudia raised, sustainability is also a function of cost versus rate. And I'm wondering, as part of this conversation, whether we're looking at the actual cost of service and the degree to which the maximization of the rates as they exist will come close to covering those costs. Or are we depending on an increase in volume to make up the difference? But either way, unless there's a real look at the cost versus rates, sustainability may be a far reach. So I was wondering if there's been any thoughts about that.
That's a great point, Howard. We have been talking about what it costs, but in this case, it seems more it's the volume that they are not getting. Because when you look at what's available and what they have used in terms of billing, they are not billing the appropriate codes for the services that they're providing. Let me just put it that way. And what we have seen over time is just evaluation, evaluation, evaluation. And we have all these assessment codes that they're not using. So it's more around them boosting utilization. And that's one of the things we want to continue working with them on in terms of how they advertise their services, how we can create infrastructure for, members to get the appropriate care at the appropriate place and the appropriate time. So I do agree with you that cost should be factored in, and we've had that conversation on a high level. But at this point, utilization plays a big role, and also having commercial payers, see this as a valid and valued service and, continue to cover it. Because I believe Medicaid is about maybe 40%, I think they said, Medicaid members is about 40% that utilize the service. So in terms of sustainability, we need everyone on board. I hope that answers your question.
Come on, I'm sorry to interrupt. I thought the Medicaid usage for the UCCs was higher. I thought it was nearly 60%, but
it is in the 40-something% range, I think, Vin. Close to, they were almost talking about like a 50-50. At least that's what they said the last time, or 50, yeah. Okay, commercial is about 40. So Medicaid will be about close to 60.
Close to 60. Okay, that's what I thought.
Yes,
And then I think they also take some military benefits as well, which like it's only a percentage or something. Okay.
Yes, thank you.
Commissioner?
Yes, my apologies for being a few minutes late. Wanted to acknowledge that I was on the call and appreciate the presentation from Fatmata. I wanted to double down on the fact that this is a relatively new service. We took a best guess at how to create the infrastructure for the service to be delivered, meaning staffing, the 24-hour conversation that I understand you all just had, Medicaid versus commercial reimbursement. And I do think we won't know, we won't be able to answer Howard's question until we maximize the billing and maximize the ability to tap into more commercial insurance. So it's just they say it takes about 2 to 5 years to understand and fully implement a program so that you can understand the best ways to have it run, and we're doing just that. I want you to know that I've spent a lot of time building up the UCCs internal to our department. I've gone to police chiefs, made presentations there, and we continue it. We've updated our mandated reporter training, which reaches hundreds of thousands of people who are mandated reporter to beef up the advertisement on the UCCs. But I think it takes all of us to put the word out there. And I believe that we can get this. It's really the 24-hour conversation is really something that I think is a little bit of a pain point. that we really do need to get underneath. Until we sort of change the model and see how that works, we just won't know. And so we're trying a lot of different things, but I do want to say very publicly that we're very proud of this service that is now out there. We believe it works. We just have to figure out a way to spread it and sustain it. And so we appreciate everybody and their assistance with this.
Thanks, Commissioner Hilili. If I may just add that in the meeting with the UCCs, they did mention that they have stopped the 24-hour care. Yeah. So we'll see.
Yeah, we had one provider that was offering it more, and
Yes.
so and I don't know, maybe we'll get back to that at some point once you get the volume. You see, everything has to sort of
Correct.
balance out, right?
Yeah.
So we just need a little bit of grace to figure this out, and we have the right people, the right minds. We appreciate TCB and DSS and us, all of us working together, and in particular the providers who are trying to, just kind of figure this out with us.
Yeah. Thank you.
Emily? No, we lost your volume. So I think we'll transition if it's okay. I'm looking at the time. We'll transition as we did ask Caroline to come and present on the fiscal mapping. And so and my understanding is, Emily, we will run the slides, and we will have Caroline let us know when to move that. So is it Chris? Chris, are you on?
I'm actually going to start off.
Okay.
Good afternoon, everyone. I'm Carrie Borden. I'm the CEO of the Connecticut Behavioral Health Partnership Division at Caroline Behavioral Health. Thank you for this opportunity to review a project that we did several years ago. It was really a labor of love with the state agencies, the Department of Social Service, the Department of Children and Families, regarding fiscal mapping. I'm here with I actually have the easy part, just the introduction. I'm here with two of the members of our team, Dr. Bonnie Hopkins, who's our Senior Vice President of Quality Analytics and Innovation. And then Dr. Chris Borey, who at the time of the project was our Assistant Vice President of Advanced Analytics. He did a lot of the heavy lifting on this project. He has since moved on to Mathematica, where he is a principal researcher, but remains a consultant for Caroline. So we're thrilled to have him here today. So with that, I will turn it over to Dr. Borey and Dr. Hopkins.
Bonnie? Or
And I just want to make sure we have Chris as well. So we're going to be going through the youth behavioral health financial map and really focus particularly on the process and lessons learned and what would be involved in updating the financial map as well. You can advance to the next slide. And again, please. So Chris will be going through details of the data, but as just sort of further introduction, I want to relay that on behalf of Caroline, Chris and I and the team work very closely with our 3 state partners of the Connecticut Behavioral Health Partnership, Connecticut Department of Children and Families, which was heavily involved across this work, Department of Mental Health and Addiction Services, and also Department of Social Services. And together we work closely on really harnessing the wealth of data available to us from a strengths-based and recovery orientation to provide action-oriented and insight-oriented data and reporting for the state partners, particularly. And we have a wealth of information on utilization related to access, quality, and outcomes, and special projects like the financial mapping. So just want to give that as our context for really, we are very glad to be here to present this work and any other work that might be helpful to the committee. Chris?
Thanks, Bonnie. Nice to see some familiar faces as well. Excited to be here. Thanks for the opportunity to present on this work. It's several years old, but still of importance, and some really strong lessons learned here from this financial mapping work. Before we start and get into some of the details of the methodology and the lessons learned, did just want to give a disclaimer and overview of what we're really going to focus in on for today's presentation. It really is, like Bonnie said, to focus in on the process of developing a financial map and the lessons learned. So what that means is that we're not going to spend some time focusing on the interpretation of specific data points. The data is quite old, and we're not going to be really focusing in on the operational definitions. But we did include some data points and graphics to kind of illustrate what it did look like and what it could look like if there was the opportunity to update the financial map with the new data. So those are really just kind of illustrative purposes for kind of showing what it could look like. The data that was used in the revised financial map was for the state fiscal year 15 to 18. So like I said, it is quite old at this point. So do caution against making any interpretations on what that type of data is and the implications it has for current. As Emily, thank you, Emily, for putting into the chat. This presentation is also a subset of information that was presented in a full report that is posted to the planforchildren.org website. So it is publicly available at your leisure. You can read 85 pages of a lot of different exciting data, but it is all there with a detailed methodology and overview and some of the major conclusions at that point. You may also see in that report and elsewhere was that at the time, the analysis and reporting was conducted by the CTBHP ASO, the Administrative Service Organization, and at that time that was Beacon Health Options of Connecticut, and now the organization is called Carillon Behavioral Health Connecticut, as many are you aware of. So quick disclaimer there. Next slide, please. Okay. To start off, just to kind of go at a high level, what is the vision and goal of the original financial map? The vision was lofty, and as visions should be, is to align and integrate Connecticut's resources to provide quality services for children and families with behavioral health needs. The specific goal, the objectives that we really aim to do under this financial mapping was to operationalize. It was kind of three parts. It was to operationalize, collect, and develop the financial mapping analysis that specifies expenditures on behavioral health network of care for children and families in Connecticut. So the three parts, the operationalize, collect, and develop, was the largest majority of the work. Operationalizing did take quite a lot of effort to have the infrastructure and being able to develop what it actually was going to look like. It is important to also note that the impetus for all this financial mapping was that there was at the time 2 SAMHSA grants that were administered to Connecticut. One was the Connect Planning Grant and the Infrastructure Building Grant. Those were in 2014 and 2015. There was also subsequent Connect grants in 2020 and 2023. And then also there were a ASSERT grants, and the predecessor to the ASSERT grant was the Impact Grant. These both, the Impact and the ASSERT, came from the SAMHSA Center for Substance Abuse Treatment, that's CSAT, and then the Connect grant was really focusing on the Children's Mental Health Initiative. At the time, SAMHSA was very interested in financial mapping across all their grantees in these 2 grant rounds. And Connecticut excelled in this ability. We actually, and some other folks on the call here, presented at a SAMHSA grantee meeting on the financial mapping process that we had conducted, because many other states and jurisdictions were struggling with the process at the time on how to develop this financial mapping. It was an honor to be able to present at that time, and we had worked closely with many folks on this call and others on how to operationalize that. It took, if folks remember that were a part of that process, it was a lot of meetings in many different parts of the state to really help to operationalize this. And so it was a collective effort to pull this financial map together. Next slide, please. So I'm going to talk about two iterations of the financial map. The first iteration, which I'm not going to go into too much detail on, was an attempt to gather information, financial data from multiple state agencies that had some type of intersection or overlap in the behavioral health expenditures per youth. So as you see here on the slide, we had 12 different state agencies participating in this process. The level of data that we received varied greatly across these 12 state agencies. Some had high level dollars, some had, for instance, Medicaid paid claims, had very specific individual level data. So the type of data that we received, and it could have ranged just from program data to FTEs to select programs and services. So the data types definitely varied greatly. All the state agencies that were participating and working with did submit data to us to collect and aggregate in total. So great collaboration amongst all the state agencies. It did require a fair amount of coordination and points of contact to be able to see where we could extract that data from each of these individual departments, which oftentimes led to finding the correct PDFs or contracts or Excel files to be able to get the actual concrete data and extract that and pull that all together. So it was a time-intensive process in collecting the data. It was restricted to just one state fiscal year. It was the state fiscal year 15 to 16. We had at that time one categorization system, and it was, like I said, very disparate data systems and very different ways of collecting the data. So we did have results, and we aggregated that on the first iteration of the financial map. Next slide, please. So this is really kind of the crux of all what we were thinking of presenting here today, is the lessons learned on how to go about doing that. So we learned a lot in that first iteration. We realized that it was quite a tremendous effort to have 12 state agencies with very different data sources and different types of data to aggregate that and make meaningful sense of the results. So in the second iteration of the financial map, as the SAMHSA grants continue to require having financial mapping for both Connect and Assert at the time, we narrowed in and expanded the scope of the work, and we had many different revisions on this financial map on the second iteration. So first, we really wanted to, in an effort from DCF and DSS to be a more integrated and holistic approach, we wanted to have not two separate mental health and substance use, substance SUD financial maps, but really wanted to focus in on having an integrated substance use and mental health financial map for children and youth. So we previously had two separate ones for both individual grants. This proved to be challenging and quite a bit of work to be able to make that revision and recode for having this integrated substance use and mental health map. We did limit it to just DCF and Husky Medicaid claims data, and I'll go into a little bit more detail on why. But basically, these two systems at that time focusing in on were the largest share of agencies that supported behavioral health expenditures and had probably the most sophistication, again, at that time on being able to deaggregate and get at some really nuanced categorization compared to other state agencies. We did have two categorization systems as well. This work was also a part of the Children's Behavioral Health Plan Implementation Advisory Board, as some folks are on and are familiar with. And so we had a categorization under that advisory plan, that advisory board. And we also had a categorization system, which I'll show in the slide next, that comes from the Connecticut Children's Behavioral Health Plan. And both of these are valuable in that they show different ways of stratifying or cutting the data in different ways, depending upon what your needs are, what the perspective is, how you want to analyze and interpret the data. So we did incorporate two new categorization systems, so that took a fair amount of effort to be able to integrate that in. We did expand the reporting period too. It was important to be able to look at trends over time, as if there were any kind of data right now, it would be important to not only just look at one period of time, but having trends over time can really be informative. We also revised on the Medicaid side at the time, revised the claims coding algorithm to be able to provide greater behavioral health level of care specificity. It was important to be able to narrow in on specific levels of care and the types of levels of care that were included in the funding mechanism. So we really had revised our algorithm, our reference table. Again, just to give it a sense of the level of work, this was thousands and thousands of lines of code and data to be able to revise this, which is a tremendous overhaul. Like I said, we wanted to have to integrate the maps, the substance use and mental health maps. So we had to create some type of primary diagnosis categorization system. There was an effort, and we were able to integrate in demographic categories. We were able to include gender, age, race, and Hispanic origin for all Medicaid expenditures, and similarly for DCF programs, select programs, I should say. And those selected programs are listed there. We did have some program demographic data from that. We did also expand the age parameters to be from 3 to 21 for Medicaid expenditures. And an important addition at the end of the grant, the financial mapping, and also probably very important now to also consider, is applying a GDP adjustment, a gross domestic product adjustment to paid claims to help allow for inflation, and being able to visualize that within the financial map of what is the adjusted GDP and also the actuals. So quite a bit of revisions on the second financial map that we were able to make. A lot was learned from the first one. The key takeaway here is that without that first iteration, many of these other enhancements probably would not have been able to, we wouldn't be able to have started off right out of the gate with these enhancements. Next slide, please. So just to, I made reference to it, these were the two different categorization systems. They may or may not look familiar. The one on the left is the categorization system from the Children's Behavioral Health Implementation Advisory Board. We were able to categorize with the work of that advisory board and subcommittees on the financial mapping. We're able to categorize and operationally define each of these different categories of universal services, targeted services, and intensive services. And the figure on the right is from the Connecticut Children's Behavioral Health Plan from October 2014. This was another categorization system on how to operationalize the different levels of care at different components of inpatient, congregate, residential, crisis, etc. So these two categorization systems were included into the financial map. Next slide, please. So, like I said, some of the challenges that we ran into. So as I mentioned, we had in the second financial map, we had both DCF and Medicaid expenditures. There were challenges in trying to integrate two different disparate data sources. So merging DCF financial records are different than DCF program details at that time, and it was a time-intensive data cleaning process. So being able to match up what were the financial payments made to certain providers, and then mapping up the program data that was extracted from PI at the time, and being able to see and matching those up was a time-intensive manual process. In order to help facilitate the eventuality of being able to update this at some point in the future, we had created quite a bit of SAS code to be able to integrate these 11 different Excel files from the financial records, to be able to integrate them into one complete Excel file and table to have a overview of all the data in one place. In addition, to help support those data sets, we had to create reference tables, which allowed for us to be able to match data across different tables. So for instance, if you have one provider name spelling quite differently, if it had incorporated at the end, or if it was spelled incorrectly, or if it was an abbreviation, you need to have exact coding to be able to make exact matches across tables. So we needed to have uniform coding across. We also created these, like I said, these categorizations for service categorizations, and including the two different ones that I previously mentioned. And then also at the time, creating a process and a reference table for applying a GDP to the fiscal actual expenditures to adjust for inflation. So we had the supporting tables to help the process. Next slide, please. Some other challenges that we ran into at the time. Oh, if you can go back one. Thank you. Some other challenges we ran into at the time was integration of demographic information. So it was from having Medicaid claims data and DCF program data. DCF's financial data was at the program level, so we could see a provider and a program had funded a certain amount, but their demographic data was at an episode level. And so that proved to be difficult to be able to merge those two. In order to prevent double counting of demographic data from both DCF and Medicaid, we had kept those demographics separately, meaning that a youth could receive DCF program services, care coordination, and also receive Medicaid outpatient services. We didn't want to double count those individuals, and so we had to keep some of the demographics data separately. So it did prove challenging to have the integration of the demographic data from both sources without having a universal identifier. If there was a universal identifier across data sources, that would allow for a deduplication of individuals. As I mentioned and alluded to before, too, the integration of disparate data sources differentiating between mental health and SUD. We, on Medicaid side, we were looking at using the first 4 diagnostic positions on a claim. Sometimes there's no diagnoses on the claims. And then at the DCF side, we were using the differentiation between mental health and SUD at the treatment or intervention type. And so slightly different approaches for how you categorize what is mental health, what is SUD, based upon diagnosis or treatment or intervention and target population from DCF. And then lastly, there was service type descriptions in the DCF expenditure data that was helpful to help clarify and classify the type of expenditures. But like I said, there was some data quality issues, such as consistent spelling of provider names that proved to be difficult to help merge and join across programs in state fiscal year. In the final report, in that hyperlink that was added to the chat, there is a full detail of the methodology. I summarized most of it here, but if you really want to look at the details, it will point you to that full report that is there. So next slide, please. Next slide. So what I wanted to do is to spend some time, I'm not going to go too much into detail because the purpose was not to kind of interpret any data points or get into operational definitions, but it is important, it is useful, I think, to be able to show what it could look like. And what we selected here were just 7 different sections on how to stratify the data in many different ways. This is just a very small subset of the ways that we actually stratified the data in the final report. Like I said, I think it was close to 85 pages. So many different ways to stratify the data. What you see here are static, shots of the data that were developed in a data visualization platform. So next slide, please. So this was just to be able to demonstrate total expenditures by source and state fiscal year. So this was to demonstrate in aggregate between a certain period of time, state fiscal year 15 and 18, what was the overall spending for youth and young adults across Medicaid and DCF. The things that I wanted to highlight here is that the solid blue bars would be the actuals, and then the lines above it are the adjusted GDP for expenditure to be able to show for an adjustment for inflation. This is a visual to be able to show, how to compare both at the same time of having trends over time and in aggregate for DCF and Medicaid, and then also applying an adjustment for GDP and inflation. Next slide. We could also then stratify, then we break apart, that was an aggregate. Now we can then break apart the data to be able to look at it from by agency. So we have, you can look at by DCF and then by Medicaid, and then in a similar process of having trends over time and being able to have absolute expenditures and a GDP adjustment. Next slide. This was for demonstration purposes. This is then I kind of went at the highest level and start to narrow down into more and more nuances here. This was to be able to look by source. So you can look at DCF and Medicaid, and then you can start to drill into the type of categorization system that we used here. This was from the Children's Behavioral Health Plan categorization system. So you have by source, by system categorization system, then by year, so you can see of trends over time, to be able to see how things are changing by different source for Medicaid and DCF. Then you can make comparisons between these two different sources and by categorization system as well. So you can kind of compare where there's more expenditures or less, depending upon what your interest is to examine. Next slide, please. This is a lot more detail. So like I said, we start to narrow down and get into even more nuances here. This was a categorization system from the Children's Behavioral Health Plan and Implementation Advisory Committee, where we were having, that was the left-hand side graphic. And again, you're able to look at by source, by the categorization system of the different types that we had, and then by year, and being able to show the absolute expenditures and the percentages across years. Then being able to compare those by source, DCF and Medicaid, so you can make some conclusions there. Next slide. This one was to then, like I said, when we had integrated the map, we wanted to be able to then not to have both mental health, SUD, co-occurring, and other. There's this other within Medicaid too, because if there was unable to be determined, again, being able to show by source, by categorization system. This one, it was by mental health or SUD, and then by year to be able to show absolute expenditures and percentages. Next slide. Now, for just Medicaid, this one was a slide to be able to demonstrate the level of detail that we were able to get at. This is the level of care detail that we're able to get at with that revised claims coding algorithm on being able to say what is total expenditures by specific level of care and where and by year as well. So you can see and sort by the year, the total expenditures by the service. For example, outpatient behavioral services was the highest at this point in state fiscal year 18. This allowed you to really drill into some of the specific types of care that are being funded. I'm sure that there's probably lots of questions about operational definitions, but like I said in the previously, that wasn't the scope of the presentation, but it did take quite a bit of work to be able to operationally define each of these different levels of care. And I know that reference table has continuously evolved over the years as new services are added or combined or refined to be able to be more meaningful in clinical classifications. Next slide, please. This was to demonstrate demographics too. So like I said, we also included demographic categorization by year. This was a demographic, we were able to select specific demographic parameters. And so this was demonstrating race for the available data that we had for Medicaid behavioral health treatment expenditures. And it was unique youth. And then at this point, you're able to make comparisons over time for total expenditures by youth, because it was youth, to be able to see any variation and change over time. So we made this as a line graph to be able to show that. Lots of different cuts of the data. Next slide, please. And then now looking at DCF services of total expenditure by service type and state fiscal year. So we were able to use the demographic data that we had from DCF and their program data to be able to then create a total expenditure by service type. There were selected service types, as you can see at the bottom there. At the time, we had these services that were selected and the financial data and program data and demographic data for these. And I think that was the last example that I had. Yes. So next slide, please. So those were just illustrative purposes for showing the different ways of cutting the data. Like I said, if you want to take more time to look at the final report, there's a lot other ways of cutting the data with a bit more explanation on the results and interpretation of the data points at that point in time. Like I said, older data at this point would be needed to be revised in order to make current implications in the current context. But in summary, some of the major methods, there were quite a bit of advancements and innovations with this iteration of the financial map. So quite a bit of lessons learned, quite a bit of work. It was a group effort for many that who were involved in this process, not only of the state agencies and being able to submit the data, but also the advisory and subcommittees that were involved on helping to operationally define and think about how we want to be able to categorize the data and then the actual analysis and reporting of the data. So quite a bit of work was done and a collective effort by many of the state agencies to support this. Mentioned the handful of selected results and then challenges and limitations as well. And I think that was it. So we left some time for questions. I think I'm right exactly at time. Next slide. Yep. Any questions from folks?
Chris, I do have a question, and sorry, and I'll go through the report again. Was there a list of recommendations, findings? So I know that what was some of the lessons learned, but recommendations or findings that were implemented?
I'm going to look at the report because it was quite a long report myself. I think there were several key takeaways and recommendations and conclusions that we did include in the report. At the time, SAMHSA also, I think, this is my own anecdote, so I'll just go on record. This is my interpretation at the time. Financial mapping was difficult for many of the grantees. And I think that it was not as strong of a push to continue with that financial mapping. However, I have heard more and seen other states also very interested in financial mapping again. So it seems like it's coming around again as an interest, not only in Connecticut, but other states in my current role, that financial mapping seems to be of interest. I'm not sure on the specifics of what those, the conclusions and the outcomes of those implementations, but others may be able to speak to that.
Yeah, and that would be great if there was anybody on this call or beyond this call, if they were part of this work, if there was any recommendations that were identified through that fiscal mapping, and if any of those were either implemented, and if implemented, what kind of outcomes or results are we seeing, and or if not implemented, why? I guess this is, as this committee is aware, this is one of the legislative charge of the enacting TCB legislation is to do a fiscal mapping. So along with what you were just saying, Chris, is to do a fiscal mapping. And that's why we invited you all here, so that we can, again, our goal is not what can we learn? What were the lessons learned? Or how do we not replicate efforts, but maybe build off of those efforts? And if there were any recommendations or findings that were found through this extensive work, whether it be with the state agencies or others, what were some of those that were implemented? What outcomes are we seeing, or what are those suggested changes that maybe this committee can take a look at and say, sort of reevaluate to see if and determine if those recommendations are still viable now. So I put that out to any member who might have participated in this initial fiscal mapping. I know that my team will be working with the infrastructure work group, Alice and Jason, who are the chairs, in jumpstarting that project. But again, I would, our goal is to jumpstart it from where you all maybe left off and see from there. Thank you. Senator Moore?
Erica, we could definitely go back just quickly and look at the recommendations and talk to some of the partners. I know CHDI was also a big partner for us. One thing I would just say is we finished this shortly prior to the onset of COVID. So it did shift, I think, the trajectory of the project as we entered the pandemic. So I think we would need to go look back, but I remember the timing being a big challenge as with the onset.
Yeah, thank you, Carrie. And I know we've also talked about, and I know, Chris, you mentioned, definitions and so forth, but again, any tools and helpful, to do definitions takes a lot of work. Yeah. And I know that you all went through that. So it would be great to learn from you all how you define the system at that time. Maybe that's a space for us to start and not restart. And it could just be that we're filling the gaps or tweaking minor changes based off of what the system looks like today. today. So again, you know, in the nature and the spirit of ongoing collaboration and in the nature of spirit of really not restarting over, you know, how do we jump off? Because there were so many people involved. And I remember that when I was at the Judicial Branch Court Support Services, as I mentioned to you all, we were involved as well. So there were so many involvements there. So how can we take what you've learned? How can we partner and collaborate and use that knowledge and build off of that? And there is a dedicated work group, which is the infrastructure work group that will be jumping into that work. But thank you so much, Carrie, and thank you, Chris. I see Senator Marr, and then Tammy.
Right. Just a quick question. I know the data was from 15 to 18, but how long did this entire process take for you to finish to provide all those graphs and come to the
question? I think the initial legwork of the operationalizing was probably the largest lift in being able to get the system down. Once we had that complete, this is going to be a complete estimate and going way back in time, I would probably say from maybe 6 to 9 months of once you kind of had the operational system in place. Then you still have to collect the data, clean the data, analyze the data, then report on the data. So I would say that's probably a good estimate, Carrie. I don't know if I would say probably 6 to 9 months probably at that point in time.
Right. I remember the largest legwork being working with the state agencies on, you know, all the data sharing processes, and then, like you're saying, the definitions and scoping out the project.
So thank you so much. It was really, in a way, almost mind-boggling, the way you were able to just keep slicing down on the information. I wonder, after you had looked at the, I don't know how to say this, not coding, but the way that after you'd looked at aligning the information, did that alignment transition then after into the agencies or the people you were working with after the collection of the information? Does my question make sense, Chris?
Alignment into, tell me a little bit more.
Let me look at your presentation and I can tell you in just a sec. When you were talking about, there was a period where you had to look at information. I'm just trying to find it here. Should have noted it when you were speaking. I'm sorry. You said you looked at two specific information that came from two specific places and you matched them up, is what I heard you say. Maybe I heard you wrong. And in order to get a continuity of information from those two data sets.
Oh, so from DCF, yes. So the DCF data that we had, you know, financial data was in one spot and program data was in another spot. And you had to, in order to make sure that you were able to analyze the data, to be able to look at expenditures by youth or by program, you had to clean the data to make sure there was exact matches between these two disparate data sets to be able to analyze that data. So that was specific for DCF, if I remember, if that's what you're referring to. But there was two different data sets. Cleaning them and matching them was going to be that was a challenge.
And
I agree with that. That's what I think you were talking about as well. Was it DCF and Medicaid data?
Yes.
And the second map, yeah.
Yeah. And I'm wondering if there was any learning from that, Commissioner Hillary, that then came back into DCF, or was this just, and not, I don't mean just, but was this for the purpose solely of the data analysis? In other words, did all the work you all did end up helping DCF in any way in terms of their framing or reporting, or that's my question.
This kind of predates me, so I would have somebody sort of chime in, but I would say the overall work was informing and instructive of, you know, of what we did going forward. But I believe it was very much in the beginning stages when we were starting to synthesize all of this. But I would have to have somebody who was here at that time in leadership, maybe Jeff or somebody else talk about that because I wasn't intimately involved at that time. Because you're talking about
15 to 18. Yeah.
Yeah, 2019 going into 2020, and then the pandemic hit. So
Right.
It did.
yeah.
I do recall that the one major takeaway that I do remember is that the data was informative for DCF's application to the next round of SAMHSA grants as well. So it was informative for the expansion sustainability grant, and using some of that data for DCF to be able to apply for the next round of dating was also important to contextualize kind of expenditures and the work that Connecticut had done on being able to map out financial impact for children's behavioral health. So it was informative for kind of the expansion and sustainability round, as well as the implementation advisory board. There were some,
right.
you know, Elizabeth, you can probably talk to it as well, is the annual summary and reports that were conducted on an annual basis. There was a financial mapping subcommittee of that implementation advisory board. There were some reports that were published, and again, Elizabeth, you can probably talk to it better than I can, that mentions the work that was done.
I was going to say exactly that. The person that I would look to for that historical perspective is Elizabeth Canada, who can probably speak to that. And I will say what I do recall, and what you said in the beginning, is that I don't think Connecticut gives itself and everybody in the call, you know, everybody here, enough credit. We are seen as like a go-to state for some of this, for some of this work, and because of some of the data that came out of there. So I just wanted to just say that, but really pull on Elizabeth because I think, and Tammy too, actually, she has her hand up. I don't, Elizabeth, did you have something you want to add? You could probably answer that question better than us.
I did raise my hand, but I'm not part of this group, so I need permission to share if that's okay with the tri-chairs.
Oh, absolutely.
Okay, so thank you, Chris and Caroline, because it's really a remarkable body of work that was done, and it was a trip down memory lane to see all of the iterations. I think that the work that was done laid a foundation, and COVID is the challenge to this. A primary recommendation was to use these enhanced data definitions and all that we learned from the process to then go forward with more current data, because the challenge to do all of this work and do it with, you know, real numbers and real figures, and then when that all was done, the data is old, and so to use the formulas and then and go forward. It may have informed some of the, you know, the federal grant dollars and some of the funding that DCF used, but the process of getting all of the input from all of the state departments was really powerful to understand how we have behavioral health spending in departments other than DCF and other than Medicaid reimbursement. And so the recommendations were to use these data definitions to do a more current analysis with more recent data, and also to incorporate commercial insurance in the same category so that we could really understand the system in its entirety. And then COVID broke out, and then we had some changes. There were definitely commercial insurance leadership that was invested in working with us on that. And so that's kind of where things left off in terms of the next work with the plan. So, you know, the Children's Behavioral Health Plan Implementation Advisory Board urging this work group to use this infrastructure, because it takes so much time to develop that, to be able to look at more current data. So thank you for the opportunity to participate.
Thank you for your comments. Tammy.
Thank you, Senator. I imagine, you know, ideally or idealistically perhaps, that one of the kind of potential future applications of having this kind of information is that it could inform this thing we all recognize we could do better, which is this braiding and blending of funding to achieve the outcomes that we want to achieve. One of the things I was curious, I imagine it was covered in the original study and maybe just not in the slides, or maybe I missed it, but I was just wondering, I can see that the sources are kind of divided into Medicaid and DCF, you know, in a lot of the charts, but I was wondering whether there was further analysis of the sources of DCF funding, just because I feel like, you know, where that money is coming from would inform those kinds of future oriented decisions. So were you able to tease out, whether it was coming from a block grant or from state funds or from a federal grant or, something else?
That is a great question. We did not go to that level of analysis. I don't remember and don't recall if the DCF financial data had tagged it in that way. I could also imagine some of even those program data were also blended and braided to begin with too. So that is a really interesting question. That would be really fascinating to look at the pathway from where it originated, the source originated from, and how it trickled through too. I could even like visualize what that would look like, but we didn't. From what I recall, I don't believe we went to that level.
Thank you.
Yeah.
Alice?
Yeah, thank you. Thanks so much for getting this report to us. Is very helpful. I guess one of the data points, and maybe I just flipped through the 87-page report we got. I don't know if there was even another larger report, so this question may be inappropriate, but what I really wanted, one of the things on that figure 3.2, which is the array of services and supports in the Connecticut behavioral health system, there's a Medicaid payer and there's a DCF payer, but I could see CSSD, Department of Education, OEC, all of those various DPH payers that even if there was the definitions, but just to see a map similar to the way the CBHPIAB has been presenting, all the different groups that work on things for children's behavioral health, but there's a lot of contributors to areas. Like I'm looking here and it says parent leadership training, which I think is a DPH funded program, or early intervention, home visiting, birth to 3 and stuff like that. So it would be, did you get this, Elizabeth, like a whole picture of all the money spent?
Yeah, that is why we did the second data definition process, because what we learned when the first fiscal mapping that Chris referenced happened is that there wasn't necessarily an understanding of what we being those who live in the behavioral health service world, might consider a behavioral health expenditure versus what might not have been. And so we went in to give more definition to different levels of care and what would be considered, so that would be a process that would inform the other departments. So that was part of the reason we did that. And again, then some deeper dive went into the 2018, but that didn't have all the departments. But that's the big picture, is that there are contributions at many levels, and we need to all understand what to count in a similar way.
Yeah,
So now we have that.
Claudia always quotes me saying that I say there's enough money, but I think, the reality is we have to see all of the various silos of where the money is and work together in a better way. DCF certainly has the responsibility of children's mental health and has done a great job. But there are multiple agencies across the board that are doing and spending money. Thank you.
Jeff?
Thanks. And Chris, thanks for that trip down memory lane. That was fun. And Andrea, I know, who's on this call and listening in, spent a lot of time supporting this too. So hats off to her. She might be experiencing like panic symptoms from the days of gathering all that information together, but she did a wonderful job there on it as well. I wanted to pick up on that last point, Alice, because it was on the screen for a moment and it just showed that pyramid, the base of which really addressed social determinants and basic needs as foundational to health and well-being. And there are some examples in our state where we're doing a good job of blending wraparound flex funds to address social determinants and basic needs together with clinical service delivery. But I really wanted to uplift that model and that concept, because I do think that at a systems level, we could, that next wave of continually improving outcomes for children and families in the state, I think will be driven in some part by our ability to continue to blend together addressing social determinant needs together with clinical service delivery for kids with behavioral health conditions. So I wanted to really uplift that one. And it gets to some of the points you're talking before. Those are dollars that are often leveraged by SDE, by DPH, by DSS. And so really that holistic view across the system of what contributes to children's behavioral health and well-being incorporates all of those pieces.
NAP data.
All right. I think any other questions from anybody else?
So is it my understanding, I'm just asking because we're in the infrastructure, Jason is on the call. Are the second definition work and also available to us, and the whatever was done on the second round that we could look at? The first report is great.
Yeah, our hope is, I know we've talked to Carrie and Caroline and Chris and so forth. Our hope is, as I mentioned earlier, that utilize if we can get access to those definitions, and as you mentioned, both Carrie and Chris, the operationalization of that. That's where a lot of that work is, and I would rather, and we could bring in Alice. My thought was that it would be a task, sort of a small subgroup of the infrastructure, bring in those key stakeholders at the state agency level, and Elizabeth, I invite you and Anne, CHDI and so forth, and we'll work together at putting a list of the who, what, when, and what were those lessons learned, and come together to say, kind of put together a project plan with next steps, actionable steps, and determine what is the capacity need to be able to do this. Alice and Jason, our hope was that we could discuss some of that too at that leadership summit workshop that Emily has scheduled in August about actionable steps.
Okay, so we'll go back and look to see what is still compiled that we haven't shared that can be shared. Some of it's mostly just going through old files more than anything, just to pull things out.
Perfect. Thank you. All right, Emily, Senator Mar and Claudio, anything else before we?
Yeah, I just wanted to thank everyone for being here today. I'm sorry that Representative Exum can't be with us. She expected to be, and then unfortunately wasn't able to. But what we all wanted to say together in one voice is our commitment to this work. And I don't know if Javid is still on the line, but if he still is in the Zoom, I wanted to say that I heard you. And this is certainly something that we have to figure out. And I know funding has always been at the bottom and the baseline of all of the efforts to provide services. So how do we figure this out going forward? And we're very, very conscious of it. And we are aware of the work that providers are doing now without being fully reimbursed, and have been doing for some time without being fully reimbursed. So it is never far from our minds. And I just don't want to leave with anyone thinking that that was not heard, because it certainly was. And thank you all for being here. Enjoy your August, and I look forward to working with you again in September. Claudio?
Thank you, Senator Mar. Appreciate that. I'll just piggyback a little bit on what you said and really try to lean into the positive, which is what you're not hearing is, despite the challenges, some of them being funding, some of them being external, imposed on our system, I think that what the conversation has been always at TCB and among a lot of the stakeholders here is, let's be creative and find a path. And that's the thing I'm really uplifted by our work going into an August break is UCCs. We identified it's a brand new service type. It's something that's cutting edge and really unique to Connecticut, and we own it, and we have to be the trailblazers at thinking about sustainability, thinking about operational efficiencies, and the fact that we're not shirking from that. And it's all of state government getting together and pulling in the right direction is really encouraging and inspiring to me. And same with the other things. I I know the easy answer is sometimes, well, if something's not funded, well, we'll just cut it. Well, that's not the answer you're hearing here today. What you're hearing is we'll find a way. The answer may not be clear. It may be muddied. It may take a little time, but the commitment's there to stay at the table. And that's what I find so transformative, to use the title of our committee here, and in the type of conversations we're having. It's how we're going to get it done. And maybe it takes a little bit longer. Maybe it's a little bit more of a circuitous path, but the confidence that we're really going to exhaust every option to get to a good outcome, if it's possible. And then I'll also echo Senator Marr's good. I used her wellness tips at the end of session. So I want to lean into the fact that we are taking August off. And sometimes the best we can do for everyone else who relies on all your good work is to also have some self-care and to reflect and enjoy with family, friends, the summer season. Hopefully it's a little slower, so that you all rejuvenate and come back in September. So thank you for all that.
Thank you, everybody, and we will be in touch for the adjusted meeting in September. We're working with our tri-chairs to coordinate calendars, but we'll be in touch shortly with an adjusted timeline around the September and October meeting, as referenced earlier in the meeting. Other than that, please enjoy the rest of your summer. Stay safe and hydrated. So enjoy. Thank you, everybody.
Thank you.
Thank you.
Be safe. Bye now.